Well, repetition's a good thing.
You see what I've read.
Rob, who's mentioned in the second half. Yeah.
Hiding.
Just you.
No, there's big 14 of us.
14?
Yeah.
Really?
Yeah.
Where are they?
It's me at the moment. I put out an advert, by the way, on John Hill's request to try and get you this.
Yeah, right. Oh, is it?
Yeah, so that should be coming out in one of the regions. 27. But you cover for the weekday.
Turn up those lights. In here.
Yeah.
Just behind you there. Just the front one.
I've been sorting out the beach red tricks.
Yeah, that's probably better.
Yeah, so the Saturday, there's only one case. It will take
They've advertised for 5 hours of work for a race.
Have they?
Yeah.
Well, that's pretty good. Because they'll be 2.5 hours. So they'll be on double pay.
Yeah.
Double pay.
I'll send that out.
Yeah, put that in brackets to.
I would do that on the way.
Well, how much is that?
55 an hour, so it's 250 roughly for 5 hours. So it's an hour and a half. They keep asking me to advertise. It's not my job. It's the manager. I mean, for finding out gaps in the race, we've got to last minute. We do.
And it's in your interest to somebody else to do it, not you.
I'm
Do that through court.
through our. If it's for more than that, if it's anything other than kind of we need to send it out by money.
So who else is on exam then?
So no one here. So John Kendall, Adam Smith. You know, Cole, Mark,
If you can, just so you keep track of them.
I had an eye intake was like 1600. You this year. Next year.
So you've done written.
That's the
My job is about
Interestingly, I don't know with and then it was talking about the first one that you guys did together. Your senior team, the 17 around that.
In Malawi.
with Castbox. Yeah. I did that. I did one of these.
I've seen it once.
There was a point of debate in the operation. When you've got your semi slung already.
Yeah.
you obviously sort of
Yeah.
stand at the top of the patella onto the anterior.
The weave is across in front,
Yeah, and you put some
I've
and
known that.
then do you always take your lap? Yeah, your lateral portion. You always go behind. And you adjust as to where instead of sitting.
on the patella tendon.
So you take your you've taken your lateral portion.
Yeah.
You divide it at the base. and
Yes.
you swing it behind.
Usually in front, actually. So take away that tension first, and then in front.
You're getting a bit of
Yeah, you shouldn't do, because that would be quite yeah, you shouldn't get too much of that.
Yeah, okay.
You lengthen the lateral rectangle as well, just
We released it and left it and the medial rectangle muscle.
if you can lengthen the lateral rectangle and repair it, then that carries a tendency to
Can you believe that? Absolutely.
But if you have problems with it, then go with the knee.
That's what we did. There's a paper that was on the slide that sat there. So it was nice
Yeah, it's probably right. Do you want to start?
Yeah.
Should we start?
It'll be sunny weather in podcast.
So guys, what I've done is, so we're supposedly covering all of the patellofemoral pathology today, this afternoon. What I've suggested, I'll just do a talk which will summarise my approach to the patellofemoral joint. But first of all, I thought it would be interesting for you to have a little summary or a little review of the literature on the risk of osteoarthritis in patients with various patellofemoral conditions, treated and untreated. Because it's quite important when you're thinking about what you're going to do to somebody that you don't cause harm or introduce a new problem, which is often traditionally what has happened. So it'd be quite interesting. We've got the risk of osteoarthritis in untreated instability, after a tibial tubercle osteotomy, after a medial patellofemoral ligament reconstruction, and after a trochleoplasty. Now, obviously, there's not going to be a huge amount of literature on this, but there is some out there, and it's quite instructive, I think, when you're thinking about what you're going to do. So you're going to kick off for us.
Yep.
Thank you very much.
Okay, so my talk is looking at patellofemoral osteoarthritis as a sequel of instability and it remaining untreated, and then following MPFL reconstruction. So at the end of the talk, I'm going to quickly run through the anatomy, biomechanics, stability, instability, and then get on to the literature review. So the trough forms a concave trough. It's got a complex 3D geometry which changes from proximal to distally. The lateral wall of the trough is highest on the anterior surface of the femur proximally and decreases in height further distally. There is a considerable difference in the bony and condylar sulcus angle. The condylar sulcus angle is a lot more open than the bony sulcus angle, which is what this arrow is showing here. And several papers strongly advocate using MRI to assess patellofemoral geometry. And trochlear dysplasia is the flattening or elevation of the central area of the trochlear groove. The MPFL runs from the medial femoral condyle deep to the vastus medialis obliquus, or VMO, to the proximal two-thirds of the patella. So the midpoint between the adductor tubercle and medial epicondyle is its insertion. The most important medial static structure limiting lateral patellar translation and provides greater than 50% of the lateral restraint from 0 to 30 degrees of flexion. The VMO has been suggested as another key component of patellar instability. Its deep fascia is attached to the MPFL and it's hypothesized to work in common with the MPFL. Its size, strength, and force is reduced in people with patellofemoral osteoarthritis, and it's the first part of the quads to weaken and last to strengthen when its function has been inhibited, which is particularly key. Another key concept in terms of the anatomy is the Q angle. So the Q angle is the direction of pull of the quadriceps tendon relative to the patella tendon. In women, it's about 15 degrees, and in men, it's slightly more open at 10 degrees. And this, as you can see, is an angle shown by a line from the aces to the center of the patella, and then from the center of the patella down to the tibial tube. It's a crude measurement, however. The distance of the tibial tubercle from the trochlear groove, which is a more accurate measurement, and that can be established on cross-sectional imaging such as CT or preferably MRI. So this just states that patellofemoral biomechanics is more accurately determined based on trochlear and trochlear groove anatomy than on bone anatomy. The infill extension of the patella is not engaged in the trochlear groove, and soft tissue restraints such as the MPFL and the capsule are responsible for stability. However, in early flexion, the MPFL guides the patella into the trochlear groove in the first 20 degrees. The distal patella comes into contact with the superior trochlea, and the correct patella positioning, as stated, is determined by dynamic and static soft tissue. Beyond 30 degrees, the patella should be centered in the trochlear groove, and the morphology of the trochlea, 30 degrees of flexion or more, becomes the primary patella stabilizer. And the height and grade of the lateral trochlear facet prevents the patella from translating laterally. Patellofemoral stability is achieved by bone cartilage morphology, static restraints, as we discussed, and dynamic restraints. It may be classified into objective patellar instability or potential patellar instability. Main causes are trochlear dysplasia, a large offset, i.e. large tibial tubercle trochlear groove distance, patella ulcer, and excessive lateral patella tilt.
Can you just put the light back on? It's not quite a bit too dark for the camera. We have a spotlight. Thanks.
Secondary causes, excessive femoral anteversion, external rotation deformity of the tibia, genu recurvatum, and genu valgum. Trochlear dysplasia was defined by Forhashkin et al. As an abnormality of the shape and depth of the trochlear groove, mainly in its proximal extent, and it's been shown to be the site of the proximal trochlear has been shown to be the site of the abnormality. The classification has been developed by Dujour and Lecourge based on axial and lateral radiographs. These have been updated to include CT as well. So PFOA, chronic instability and recurrent dislocation of the PF joint may lead to patellofemoral osteoarthritis. Prevalence, so in 100 random cadaveric specimens, PF degeneration was detected in 79% of knee specimens with an average age of 65 years. And radiological evidence of isolated PFOA in patients over 60 was 14% or 13.6% in women and 15.4% in men. The risk factors identified include abnormal PF joint alignment, abnormal trochlear morphology, and kinetic and kinematic abnormalities, as well as the further 4 risk factors. The study looking at 60 knees, both acute and recurrent dislocations, so 13 each group. They showed that the initial insult appeared to be the cracking of cartilage on the central dome and medial facet of the patella. And this seemed to be the initial insult in the progression through to patellofemoral OA. Second paper looked at the comparison of 118 PFJR patients with 116 unicompartmental patients regarding their recollection of anterior knee pain. A significant number, 22% of patellofemoral patients, report anterior knee pain as a young adult or adolescent. And this is part of the process that people aren't necessarily picking up initially and leading to untreated instability. So then there was a case control study looking at 222 patients with patellofemoral OA and compared with controls with unicompartmental tibiofemoral OA. And it showed that patients are more than 3.2 times more likely to develop patellofemoral with the previous patella dislocation. And then this was a systematic review which had included several studies of dubious quality, but the authors felt that there was sufficient evidence to include strong evidence of a relationship between knee alignment and trochlear morphology and patellofemoral OA in people with knee osteoarthritis or other knee conditions. And this is a large MRI study looking at 1,100 knees in the United States, where they found that edema in the superlateral half fat pad was more likely in patients in the highest quartile with large trochlear angle, large offset, and a large incise-salvati ratio corresponding with patellar artery. And then this is another MRI study, slightly smaller, but what was interesting was that they performed this in upright 3D MRI scanners, and they found that they were able to establish that the patella in patients with patellofemoral disease were 2.4 millimeters laterally translated and 3.7 millimeters more proximally translated as well. Going on to MPFL, so just a quick rundown of the MPFL anatomy. Reconstruction, its instability with normal offset, and its indications are instability with a normal offset or temporizing measure in adolescence until the physes close. A hamstring graph is used and often can be arthroscopy assisted to visualize the medialization of the patella, and in adolescents, considering extra or intraosseous fixation without violating the physis. Reasons not to perform MPFL in the literature, reasons were given were bony alignment, trochlear dysplasia, and patella alta. So 211 case series showing no recurrence in dislocations or patients following MPFL reconstructions, which is good, as we established earlier that recurrent insult to the patella can cause patellofemoral OA. However, the only issue is that it was a 16-month follow-up. Slightly smaller study looking at 18 knees showed that there was no evidence of patellofemoral osteoarthritis at the median 10-year follow-up. And again, 24 knees from Japan at about 12 years of follow-up showed minimal progression of osteoarthritis. So in conclusion, chronic instability is implicated in the development of patellofemoral osteoarthritis. The initial insult is to the patella as opposed to the trochlear. Repeated chondral damage, possibly the instigator inflammatory process leading to the degenerative changes, and MPFL reconstruction shows good results with isolated medial structural incompetence. Patient selection is very important. Thank you very much.
Very good. Thank you very much. Fantastic. So you think it might work?
Yeah, there's quite a lot of it. There.
Good. That's brilliant. Anyone got any questions about that? Okay, so I recognise a few of those slides, so there will be a bit of repetition. That's always a good thing for learning. If you've got any questions about this as we go along, just stick your hand up and ask. Don't wait till the end. There's quite a lot in here. I still obviously can't cover everything. Your little biomechanic bit was really nice, and the kinematics and things, so that's very helpful. So, as I say, any questions about any individual areas, ask me as we go along. At the end, if I haven't covered anything you particularly wanted to know something about, then just give us a shout at the end. So, the first thing, the patellofemoral part of the knee is it's by far the most interesting. Traditionally, it's the bit that everyone shied away from because we haven't understood it and we've treated it really badly and the patients do badly. But there's no doubt that recently our understanding of it has improved a lot. The way we treat it has definitely improved a significant amount. And actually, these patients can be some of the most grateful patients that you'll see. They get really good results if you treat them well. And if you think about them and don't just dismiss them all, send them all to physiotherapy. So there is no doubt that there are a large number of people out there with anterior knee pain who have no problem with their knee. And obviously, surgical treatment for those patients is a disaster. So the first thing is you've got to assess the patients properly before you consider any form of surgery. And you've got to be, you've got to be firm with these patients. If there's nothing wrong with them, you tell them there's nothing structurally wrong with them, and that the surgery is absolutely the last thing they should have, and will harm them rather than help them. And you should discharge them from your orthopedic clinic, not send them for a second opinion, because that will reinforce their view that something might be wrong. So if there's nothing wrong with them, tell them that and discharge them, or help them with their pain management through other methods, but not through surgery. And when you're working out, when you're deciding whether there is a problem that might get better, and these patients would have been through a long filter before they get to any form of orthopedic care. These are the sort of things that I basically think about. Does this patient have overload of any of the structures in the joint, either due to a repetitive strain thing or due to structural abnormality? Do they have true or potential instability? And do they have arthritis that could be painful or causing instability or rocking or giving? All those symptoms that patients can describe but don't necessarily direct you immediately to what the problem is. So overload is probably the least common of these three. And there are a number of conditions that I think people don't recognize very well and maybe don't understand the best way to treat. So these are patients generally who will be presenting with pain. They might be very specific about where their pain is. A lot of the patients are actually, they can point to it. And I'll show you some of the conditions that they can do that with. But others will just say it hurts. Patellofemoral pain very often presents as posterocentral knee pain. Patients, it hurts right at the back here. It's actually the patellofemoral joint that's the origin. That's really common. So if there's a patellofemoral problem you think might be painful and they will say it hurts at the back, it's still likely to be the patellofemoral joint. So don't rule that out. So there can be some significant structural problems. And patella alta, so this is your one real take-home message for today. If there's nothing else, is look for and if appropriate treat patella alta, because this is a really powerful problem that causes lots of patellofemoral symptoms, and it is easily and very successfully treated. So I do a lot of this now, much more than I was doing 5 years ago, and much more than I was doing 10 years ago. So increasingly, my sort of threshold for treating alta is decreasing all the time, because it works really well. And then there are torsional abnormalities, so this miserable malalignment that you all hear about. I'm not going to talk about that really, other than just to point out that it is there. It's really uncommon that you'll see a patient in whom it's appropriate to break all 4 bones of their limb, move them around. But it does. We do see them, and when you treat them appropriately, again, it works really well. And again, actually, I think my threshold is decreasing for treating this, because again, it works well. But it is major surgery and significant surgery. So the patients will need to be aware of that. So patella alta has traditionally been defined using these 3 ratios at the bottom: the Insel-Bernstein, the Caton-Deschamps, or the Blackburn and Peel. And the problem with all of those ratios is if they reference some point on the tibia as to where the patella is sitting. And of course, what's important with the patella is where it's sitting relative to the femur, or specifically the trochlea. And so the patellotrochlear index was probably described first by Roland Biedert, and then Damien Clark and I have looked at that in patients with instability and trochlear dysplasia. And there's sort of a definition of normality of patellotrochlear index is that 1/3 to 1/2 of the patella engages in the trochlear groove on a full extension MRI. So you said, Fulkerson said that with kinematics, the patella is not engaged in the trochlear extension. And that is a sort of common view, but actually it does overlap the trochlea, normally between about 12.5% and 30 to 50% of the patella. And if it's not engaged, then you're at risk of all of these conditions that you can get with patella alta. And then a low patella is more than 50% engagement. Okay, so So, this is an MRI scan. Look for it. I'll show you clinically how you can sort of trigger in your mind, does this patient have patellar alpha or not? And then an X-ray, unlikely to show it very clearly, MRI will show you. So these are two axial T2 or fat suppression MRI scans, axial sections of the knee. And they both show very significant problems. So on that left one there, you can see the trochlea. You can't see the patella. So on a normal patient, you would be able to see the patella on the scan. It's not there because it's high, and as a result of that height, the patellar tendon is perching on the lateral corner of the trochlea and is pinching either the fat pad or just the tendon between the two. So you can see a big bright white area, which is inflammation and pain. So that's what Charles Wakely and I sort of called lateral patellar tendon conflict. It doesn't really matter what you call it, but it hurts. And the patients will say, my knee hurts here, and it specifically hurts there when you examine it. It's very specific. And just, yes, that's my pain, that's exactly it. So you can imagine that if you correct the patellar height there, that just takes the load off straight away, and it can relieve the pain. On the other side, you've got proximal central focal patellar tendinopathy. So this is what people sort of call jumper's knee, and it's a very localized condition. And on this one, if you do a test called Latzina's test, where if you press down on the superior fold of the patella and put your finger in there, it hurts them. If you then put the knee like this and press down, it doesn't hurt them. So that's Latzina's test, and it's very specific for picking this up. So my knee hurts around here somewhere. It hurts after activity, not usually during, afterwards. And then it goes away with rest, and it comes back as soon as I exercise again. And if you've got this in combination with patella alta, it's unlikely to get better with non-operative management. If you have it without patella alta, which you can equally get, then most likely it will get better with non-operative management. Either way, you should try non-operative management, but you know that there's a chance it won't get better if there's alta. And then here we've got, this is overload associated with patella alta, where where the patella first engages on the trochlea, you can imagine there's a huge amount of pressure on a very tiny area. Or a huge force on a tiny area, so very big pressure, which basically causes degenerative change ultimately. Pain to start with, and then painful degenerative change, usually of the medial distal patellar facet and the proximal and lateral trochlea. There's not the lateral patella, it's the distal medial patella where you get the problem. And then, so torsional problems do exist, but I think this tibial tubercle trochlear groove offset measurement has been a massive red herring for many years, and people have been measuring this obsessively and then trying to work out what's normal, what's not normal, what's pathological, and then doing operations to correct it. And unfortunately, what generally has happened is it's been hugely overcorrected, and that's caused more harm than it's relieved. So my view generally is that the trochlea is almost always the issue, and very rarely the tibial tubercle offset. But there are some patients with torsion. It can be intra-articular torsion, it can be extra-articular, either just the tubercle or rotation of all of the bones. That gets quite complex. But I've only done a tibial tubercle medialization once in the last 2 years, and I operate on the tibial tubercle every week at least twice. So it's very unusual that it's appropriate to medialize the tibial tubercle. So I think that's something that we really need to think less and less about. And so on the left here, you can see, and you're going to see this X-ray quite a few times through this afternoon, and basically that is a massively over-medialized tibial tubercle. The other interesting thing you can see on this X-ray here is that it's a perfect AP of the tibia, and it's a very oblique view of the femur. So the femur is sitting internally rotated on the tibia, and there's an intra-articular rotation problem. And basically what that patient probably had was femoral anteversion, or external tibial torsion, or and then when you get an X-ray front on of the tibia, you see a rotated femur. And so somebody's tried to treat that by moving the tibial tubercle, which will have just caused arthritis. So much more, we're going to be hopefully thinking about doing an osteotomy more like the one on the right, where the tubercle has merely been taken distally and not medially. So this would be a perfect case in a patient who's failed non-operative management and has the symptoms and signs that fit with this scan of lateral patellofemoral conflict, where just a tubercle distalization of the appropriate amount, not overdoing it, just relocating the patella into the trochlea and extension will resolve the symptoms. So that's sort of overload, structural overload. So there are then tendinopathies. So this is a proximal central focal patellar tendinopathy without patella alta. And so that's likely to get better just with non-operative management. So these you would very, very rarely operate on. And if you were operating on it, it's rather difficult to work out what operation you would actually do. But generally, I would decompress the proximal tendon and probably excise that extra articular distal fold of the patella, which is causing the problems by repetitive impingement into the tendon. But it's a very unusual operation to do. So most of these will get better. No alta, probably don't operate on. Okay. So physiotherapy and an eccentric 3-month eccentric loaded exercise program is what your prescription should be for these patients. And at least 60–70% will get better in that period of time. There are all sorts of other injectables that people are using without much evidence. And then, there are plicae around the knee. Okay, these can cause pressure again. It's sort of very unusual. But this is quite interesting. So this is a suprapatellar plica. Looking at this from above, through a suprapatellar portal, and as the knee flexes, the plica, compresses the patellofemoral joint and rubs on the condyles of the trochlea. And if they're soft, they don't cause any pain. If they harden after inflammation or an hemarthrosis or some form of trauma, they can cause pain. The problem with these, you can't see them on an MRI scan, so it is a clinical diagnosis, and you don't want to be scoping hundreds of people with anterior knee pain just in case they've got a plica. So it's something that you'll only rarely be treating. So has anyone got any comments about overload or other pathologies they've seen that they've noticed? Okay. So moving on to instability. So this is a very large proportion now of the sorts of things that we can treat very successfully if it's done properly. So as we heard, Henri de Jour in 87 divided these patients into objectives, so that's people who have dislocated, potential instability patients who have anatomical predisposition to instability and symptoms but haven't actually truly dislocated. And then there's the painful patella syndrome, which is the patient I was talking about right at the beginning, who absolutely doesn't need our services, but needs pain management and various other approaches. So I'm not going to talk about them. So again, as we've heard, trochlear dysplasia and patella alta are the two structural abnormalities that predispose you to patella instability. And I'm not convinced by this excessive tibial tubercle to trochlear groove offset. The other thing about dysplasia while we're here is that a dysplastic trochlea medializes the groove. So if you're measuring the distance between the groove and a tubercle on an overlap 3D scan, if the groove's gone medially, your offset will appear to be bigger, but it's a false raised number. It's not the real raised number. And we're just trying to publish a paper on that at the moment about where the trochlea should be and where it actually is in patients with instability.
Can I just ask that? So were those the three main points that de Jour sort of focused on in his paper? What out of interest,
so
why?
He said he suggested that he didn't really worry too much about alta. He did believe that dysplasia, and I'll show you their figures, dysplasia was important, but he equally felt that raised TTG was very important as well.
And was that the reason why then everyone focused so heavily on TTG over the?
Well, I think before, yes, probably. I mean, de Jour didn't define the tibial tubercle trochlear groove offset that had been around before du jour. But du jour really was the first person who tried to think about instability and categorize it and work out how best to treat it. So I think du jour is really the person who really led this. And that's probably when, I mean, there were, the Elmsley triar medialization was around before du jour did this work, so it was still being done. And then, so secondary contributors, of course, on here should be joint hypermobility, which is really important. But these are structural anatomical problems as opposed to hypermobility. So femorotibial torsion, you do need to assess and make sure it's not excessive. And again, with genu valvum and recavatum. It's very hard to define what the actual number should be, where if it's above that, you would treat it. I haven't got a number in mind. It's just a sort of, that's a bit of a feel group. So these patients can give you, can be very non-specific about their needs, about what's going on. They might, although their patella is actually dislocating, they might not perceive it as dislocating. So that they struggle to describe their symptoms. There are lots of ways that they describe it. And they probably, well, unfortunately now, more recently, more and more patients haven't had previous surgery, but a lot of them in the past, did have. So, the very non-specific, strange symptoms that people describe. And they can be, patients with recurrent patella subluxation or dislocation are severely disabled. They withdraw from society, and they do eventually get mental health issues as well. And unfortunately, we often don't see them until they're really in terrible trouble with it. But it's not, the mental side of it shouldn't mean that you don't treat them. And they are often overlooked and dismissed, these patients. So if you suspect this is going on, your examination obviously will be a general musculoskeletal one, a general knee examination. ACL and MCL injury very often coexists with patellar dislocation, and they're very often confused with each other. So you'll see a patient from A&E query ACL rupture and actually they've dislocated their patella, and vice versa. So they often coexist. And then Toby Smith is a physio from Norwich originally, now working in London. He's done a lot of work on the patellofemoral joint, and he through the literature has found 18 tests for the patellofemoral joint, 5 of which he felt might be reasonably accurate. I'm not sure if it's even that many really. I rely more on, is it happening, and then what the investigations show, rather than trying to work out what to do based on an examination. So you all know the Bateman criteria for joint mobility, and the Brighton variant. Limb alignment, so look at angular profile, valgus varus, recavatum, and then torsion. You want to look at the overall foot progression angle, what's the 5-foot angle with the knee and the foot at 90 degrees to give you an idea of tibial torsion, and then hip internal and external rotation, ideally prone, so you can see what the femoral version is. And I think that examination is really as good as CT scanning, really. I think that the limb recon boys and the VRI sort of vary a bit between using CT and not, but I find that the clinical examination gives you a very accurate picture about what the limb torsion is. And then you've heard about the Q angle or the spine sulcus tuberosity angle, which give you an idea sort of about is the patella being pulled more laterally than normal by the quadriceps. But again, it's very non-specific. So patella height, I'll show you when Honor comes in, how I just have a look clinically for patella alta, very briefly, just a quick look, does it look high or not, based on the knee at 90-degree flexion. At size, I don't think is relevant at all, really. So I think the thing that is quite helpful is the apprehension test, again, which I'll show you, and how the patella tracks going from a flexed knee to an extended knee, bent over, sitting up, leg over the couch, just get them to actively extend the knee and then drop it down again. Feel what the patella does as they do that. And it's amazing how many patients actually can't fully extend their knee over the side, off the side of the couch if they've got patellofemoral torsions, true patellofemoral torsions. So the general musculoskeletal knee, specific knee, and make sure you cover it all. And then in terms of investigations, so it's all common sense really. So you need an X-ray series. I don't think we should be treating or assessing these based purely on scans yet. Scans still miss things like loose bodies, for instance. So you do need a knee series. And actually, probably the lateral X-ray is the most useful for patellofemoral pathology, rather than the axial VP. And so on the lateral, you can measure those three previous indices of patella alta. As I said, I use the MRI patellotrochlear index nowadays, and you can see the three lines of the trochlear groove. So A is the deepest part of the trochlear groove. B and C are the walls. And so the crossing sign that you'll hear about diagnosed dysplasias is where A, line A, crosses in front of line B and or C. And so the floor of the groove is actually in front of the side walls of the groove. So it means that you're, you haven't got a groove, you've got a bump or a flat surface. So you can see those lines on there, possibly on there, projecting on that. The merchant's view, I kind of, so it's sometimes helpful. It can show you little avulsion fractures and trochlear fractures. There are described the lateral tilt angle, the congruence angle, and the BORG patella types. But I don't find any of those in the slightest bit useful. But they are things that somebody might expect you to know that they exist. So there they are, but they don't really. They're not prognostic of anything. They don't guide treatment. And we published a paper from MRI scans showing that in dysplasia, your patella shape can go from the bottom to the top one as you move from distal to proximal on the patella. The distal patella articulates with a dysplastic trochlear extension, and as your knee flexes, you go on to a more normal shaped trochlea and more normal shaped patella. So you can have all of the patella shapes in one knee. So it really doesn't help. And so this is de Jour again, how he defined radiologically the presence of trochlear dysplasia. It's with a shallow groove on the axial scan, so an angle of greater than 145, and the crossing sign, that's a poor crossing sign on there, so this is a better one. You can clearly see there, that's the floor of your groove crosses and becomes a dome. And you can see this patella is well engaged in the trochlea, can't you? And this is already becoming degenerate. So de Jour and the Lyon group found that a shallow trochlea and a crossing sign were present very commonly, almost always, in patients with instability, and very rarely, if ever, in patients without instability. So trochlear dysplasia is always, to some extent, present in patients with recurrent atraumatic instability, not necessarily traumatic instability. And it is a condition of the proximal trochlea. So, although those signs are present on that axial view, actually the MRI scan with its various sections throughout the length of the trochlea gives you a much better idea about the shape of the trochlea throughout its range. And you can use CT, but really the important thing is what's the shape of the cartilage surface, not the bony surface, and they're very different things. So with CT, you really need arthrography rather than just CT. So you can get that on the left. So CT arthrogram shows you the surface of cartilage, but a normal CT doesn't. So you can underestimate dysplasia on a plain CT scan. We've heard about these. So de Jour's son gave us the 4 types of dysplasia based on X-ray and CT sections. It's very complicated. I remember it while I'm listening to them talk, and then I've forgotten it when I left the theatre. So I don't use this, and we're again with Anthony Barnett up in Oswestry are now have in press, I think, are just the Bristol grades, which are very simple. There is none, and there is mild, which means it's shallow, it's moderate, which means it's flat, or it's severe, which means there's a dome. And that's basically what this says, but it's much more complicated. And that's the classification on which I've based all of the series that we've published over the years. So you can see these are some of the MRI scan studies that we've done. And Van Houston actually didn't. What did you say you've done?
So in his paper, they'd put a definition of trochlear dysplasia.
Okay, so yeah, so this is Adriano, who's a fellow here.
Okay.
And he didn't define trochlear dysplasia. We just basically define the MRI signs on there.
Okay. Thank you.
It wasn't RI. But mild, moderate, and severe, and I'll show you maybe a load of cases at the end of the afternoon, and just show you the different types of things that we're looking at, and ask you what you would do with them. And hopefully that's the way people sort of understand what we're talking about here, really. So you do need MRI scan to demonstrate the severity, and I think surgical planning in instability really revolves around the frequency of dislocations, the level of disability, the presence or not of hypermobility, and then the MRI scan findings. So very occasionally, this video won't play, but very occasionally I've had to do an arthroscopy just to understand what's happening in the joint, because you know, even with a clear history examination scan, you still can't quite work out what's happening, what the patella's doing. This is a good example of why you need later on to use the superlateral portal. So this is the same knee viewed from the anterolateral portal, top left there. Can you see that? Is it too bright, or shall I just? Do you mind if I'm thinking? Is it this one?
It's the one on the left. The left, yeah.
Yeah. So this is the same knee. Okay. So that you scope that anterolateral portal, normal knee. Yeah. You wouldn't say that's a problem. No apparatus at all. Through the superlateral portal, this here is that groove that you can see. This is a big dome, and the patella basically trapped down here and pinged across that way. And so it's a severely dysplastic trochlea with major instability, which if you do a scope down in the treatment centre, a quick anterolateral portal, there's no problem with being discharged. Again, that poor patient's been really badly served. So the superlateral portal is really important in patellofemoral pathology and surgery. So you must use it, and these are the views you get, and it totally transforms your understanding of what's going on with the joint and your impression of what you've achieved with any surgery that you do. So we're really lucky to have Charles Wakely in Bristol and a number of radiologists up here in North Bristol as well. MRI is important, and learn to use the superlateral portal if you're going to treat these patients at all. So symptoms can be badly described, examination is important, and then radiographs and MRI. So in terms of treatment, non-operative obviously needs to be pursued, at least for a while. And then if there's a significant structural abnormality, then operations are appropriate. And these are all the things that can be considered. So trochleoplasty, just very briefly, this is the de jour, this is the Lyon type of trochleoplasty, which is a thick, flat, cracked in the middle, knocked down. And it's basically, a trochleoplasty is an umbrella term for operating on the trochlea. So there are some operations like the ALBI, which is elevating the lateral side, which is clearly completely the wrong thing to do if someone's got a high middle and normal walls. What you want to do is deepen the center rather than raise the side wall. So a deepening trochleoplasty is the right thing to do, not an elevation. That's the de jour technique, and this is, I used the Bereiter, which came from Chur in Switzerland. And these are patients who you think of using it on, so from skeletal maturity until degenerative change has struck in the joint, which is usually the early 30s. Although amazingly, even some 18-year-olds can have quite bad patella damage. Severe dysplasia, it's not for anything less than that in my hands, and limited, if any, degenerative change. So this is the sort of thing that you might be treating. So severe displays a big bump approximately, and then a nicely formed, reasonably congruent groove at the end of the procedure. So there's MRI scan at the top and an X-ray. That was the first guy I ever did in Bristol in 2002. Still going strong. So that was our original series we published in 2008. Seemed to be working quite well. So on the basis of that, I carried on, and the numbers have increased quite significantly. That is again somebody that was successfully treated. I put that in the paper, and the reviewers refused to publish it unless we showed that we successfully centralized that patella. They didn't believe that we could treat that. Then we had, fortunately. So it got published. So, and then more recently we published a bigger, longer series, and still the results are holding up. So these are all patients with recurrent atraumatic, either permanent, habitual, or recurrent dislocators, all with severe dysplasia. You can see it's much more common in females, and these are generally young patients that you're treating. All of them have a restoration of normal tension to the medial structures. So I personally don't do a medial patellofemoral ligament reconstruction with a trochleoplasty because I think it can be unforgiving and too tight. And when I do an MPFL reconstruction, I do it with a superlateral scope port. And when you're doing trochleoplasty, the knees are open, so it's harder to judge tension. So I just restore normal soft tissue tension to the native VMO and MPFL, and very occasionally you might have to go back and do some, an MPFL reconstruction later. But there are very few patients who needed that. And then more recently and more frequently, I'm doing a tubal osteotomy to distalize the patella at the same time. So that not many of this lot had it done because I wasn't doing it very often. But now the numbers would look very different if you looked at my series for the last 5 years. And there was one chaos, I think, in that series. We've now got about 5. So no infections or DVTs, interestingly. I haven't given them any thromboprophylactic medication, despite one parent protesting vehemently at me about that. I had one guy who it transpired after I'd operated on him. He had manic depressive disorder and played football 6 weeks after the operation. So he had a partial detachment of the lateral flap. I went and took that out to the microfracture, and actually he's still playing football. That was 10 years ago. So that wasn't too bad. But that's what I'm totally worried about every time I do a trochleoplasty. If flap fails to heal, you've caused a terrible condition in the young person. So that's my worry with this. And a couple of dislocators, or sort of subluxes really, no true dislocations. And a few subsequent operations. That's an 8-year after trochleoplasty arthroscopic image. So it heals nicely and the cartilage survives generally. So the yellows were the subjective outcomes of the year, and then the blacks are the bigger series. So slightly less subjective, less good subjective outcome. I mean, it's still quite good, more than 8 out of 10 cat owners, so it's not bad. But and when you think about what these patients are, severely dysplastic, some permanent or habitual dislocators, that's pretty good. It's miles better than any of the other operations that people do for this. And this is the interesting thing, I think, that so these are the pre and post-op scores. So they do get a lot better, and markedly so. And the interesting thing is that a lot of you will know what a patient after an MPFL reconstruction looks like, or indeed after an ACL reconstruction. And those are the scores on the left of MPFL, my series of MPFL reconstructions. And then you look at the scores of trochleoplasties, and they're almost identical. So I was quite pleased with that, really, because I thought they would be a lot worse than the MPFLs. But in fact, the results almost mirror each other. So I think that's quite reassuring that it does work well. Anything on trochleoplasty? No. So that's sort of that's small print really. So the MPFL is obviously something that it is becoming much more understood, and a lot of people are operating on this. So we've heard a bit about its anatomy. It's reasonably long, but because it fails at about 30% of strain, it has to rupture for the patella to dislocate. So it's always ruptured if you have a dislocation. So the MPFL, if you have a patient with recurrent atraumatic instability, dislocations, and mild, moderate, non-mild or moderate dysplasia, they are the patients who will be well treated with MPFL reconstruction. And then there are some other patients who you might use it on as well. So the skeletally immature, even if they've got severe dysplasia, just to get them over the growth period until they might need a trochleoplasty. They almost definitely will, because they all fail in patients, in kids with severe dysplasia, but they do work for a while. Patients with a single or 2 or 3 traumatic dislocations who can't rehabilitate back to normal. And then some patients with degenerative disease and severe dysplasia who you don't want to do the more radical procedure, maybe of a joint, joint replacement. But you have to be aware of pain with it, because pain can be potentially quite an issue. So this is the sort of patient that you would use this for. So assume this is a 25-year-old with recurrent atraumatic dislocations, maybe a bit of joint hypermobility, maybe a little bit of torsional abnormality, but no patella alta. The better ones of you might can see a little fragment of bone in the lateral gutter there on the X-ray. It's interesting that you can't see it on the MRI scan, so you do need X-rays. On the lateral X-ray, it doesn't look like there's a crossing site, so there's not likely to be severe dysplasia, but you do need an MRI scan, and on that you can see the signs of an acute dislocation with bone bruising on the medial patella and lateral trochlea, and you can see the patient's got mild dysplasia, so a shallow groove. So perfect for an MPFL reconstruction. So this is the arthroscopy before you do the reconstruction. You see where the patella is sitting, and that's just because of the incompetence of the static stabilizer of the knee and extension. So the patella sits laterally subluxed. That's going to be symptomatic boundary. And then that's once you've done the MPFL reconstruction, which you see in the medial gutter there, sitting outside the synovium but below the other layers of the knee. And Nick Howells published my series, which you quoted earlier on, so we've seen that. So 96% follow-up at 16 months, which was not bad for this patient population. So as you see, the vast majority atraumatic recurrent dislocators, a few recurrent traumatics, very few pain with subluxation, but without true dislocation. You'll be wary of those because they might bite you. They can still have pain and stiffness afterwards. And then a very few sort of elite level athletes who have had one dislocation and can't rehabilitate back to the same functional level because of the slight patella maltraffic. And they do well, but that's very rare. That one. And you can see that none of these patients had severe dysplasia, which would be this. So you don't treat this with an MPFL reconstruction, but you can treat the other two. So most of them are moderate or mild, moderate dysplasia, a few mild and very few normal trochleas. And then you've seen the results. So very few sort of complications are low. You will get them, but it's not a high risk procedure. It's a bit like an ACL really. And they all do really well. We haven't had any recurrent dislocators, which is quite nice. But in terms of functional outcome, female atraumatics who generally have a bit of joint hypermobility as well, functionally are less good, and that's what you'd expect really. That's just normal for their condition. And if you've had prior surgery, are less likely to do well. And now I've done hundreds of these now, and I've had one recurrence over the years. But they can have medial pain where the graft sits, which persists until the VMO has rehabilitated back to a good level. So distal realignment. So here's that X-ray again that you see. Overcorrection usually is a disastrous thing to do. So in patients, almost invariably now with patella alta. So treating patella alta with a distal realignment, really good operation. Reversing patella infra is a bit A-level. High tibial tubular trochlea groove offset. I'm not sure it exists anymore. and reversing previous surgery is something that I did quite a lot, but fortunately doing less and less now. So this is a patient who has patella alta and recurrent instability, moderate trochlear dysplasia, I'd say that was. And so they're ideally treated with a slight distalization, not overdoing it, and medial repair, or now I do an MPFL reconstruction at the same time. We'll go through that a bit later. These were Chris Ackroyd's Elmsley Triar operations that I just reviewed about 15 years ago, no longer than that. And they do, so if you over-medialize the tubercle, it does treat dislocation quite well for a period of time. It treats subluxation quite well, and even osteoarthritis quite well. But somebody's going to talk to us about it. Yeah. So have you got this paper? These two papers? No. Okay. So these are quite important because so you can see that patients with instability in their series, if they weren't treated, didn't get arthritis very often. But if they had the osteotomy that they were doing at the time, 10 years after the operation, the vast majority had arthritis. And this is, I'm sure, because they were doing a massive over-medialization of the tubercle, which is pretty much what an Elmsley or a Fulkerson osteotomy is. So, you know, you might think that it's good to cure their instability for a short period of time, but then you're going to cause arthritis, which is harder to treat. So I think medialization is something that should be avoided unless it's absolutely necessary. And then in terms of how to fix and rehabilitate tubercle osteotomies, so for years I was using two 4.5mm cortical screws. We had one fracture in the BRI at the distal end of the osteotomy, and a couple of delayed unions. And I was just sort of pondering how is there better ways of doing it. So we moved to 3.5mm screws. Still rehabilitating the same way, and then more recently we've been doing this fixation on the right, which is a third tubular plate, a couple of small cortical screws which span the osteotomy. So the osteotomy stops here. The blocks, you cut out the domino, take a block of bone out, move the tubercle down, and that stops here. So the plate spans the distal part of the osteotomy. Two screws. The distal one could, I suppose, be unicortical, probably wouldn't be any different. And then two compression screws through the osteotomy itself. And so I've changed the rehabilitation now from bracing for 6 weeks. I still allow them to fully wait there in a locked extension brace and then do full range of movement from day one. But I was doing that for 6 weeks with those two fixations on the left, and now on this one on the right, we're just doing it for 2 weeks and then getting rid of the brace. So the patients are much happier like that. They're definitely getting less pain. And at 6 weeks, they walk into clinic with a normal gait as opposed to coming in with a limp and crutches and a brace. So it's much better. What we don't quite know yet is, are more people going to be symptomatic with the metalwork and need it or want it taken out? If they are, then I'll give them the option of the two fixations and the outcomes, because I think the one on the right is by far the better. So, and then arthroplasty does have a role to play in these patients. So this is a young patient with severe dysplasia, recurrent instability, and end-stage arthritic disease. So you could either say there's nothing we can do, or you could do this. I don't think this should be done regularly by lots of people in the country, but I think it does work if it's done well. How long it's going to last, we don't know. But I think in young patients, it's looking like they're going to last for a long time. The major cause for failure of this is disease progression, and there's no reason why this patient should go on to get disease progression. So secondary arthritis to instability and dysplasia. The tibiofemoral joint's normal, so I think that will be a reasonably good outcome for a long period of time. So always with these patients, if you can at all, early active rehabilitation. Don't brace acute or recurrent dislocators. Brace them if you operate on them and do a tubercle osteotomy, but otherwise don't brace them and certainly don't immobilise them. Immobilisation is terrible for these patients. So that was instability in a nutshell. Anyone got any burning issues? No. So, so finally, arthritis, so patellofemoral arthritis. So lots of studies on the incidence prevalence of this. This was an archaeological dig that was done by the archaeologists from Bristol University a few years ago. So they found isolated patellofemoral arthritis in about half of the skeletons that they looked at. In Prof. Diep's community study that was done in Bristol many years ago, they had 2,000 subjects. Some of them had painful knees, 400 of them. So they did X-rays, and as you can see, about a quarter of the females and a tenth of the males over 55 had isolated patellofemoral arthritis in their painful knees. And then this was Andrew Davis, who was a registrar here a while back, now working in Swansea, I think. So he just did a review of knees presenting to a knee clinic who had X-rays, and he found that there was isolated patellofemoral arthritis in 9% odd of those. So it's, you know, it's not uncommon. Certainly, it's you know, it's reasonably common. Investigations, same. So assuming these are patients presenting with pain, swelling, maybe some instability, giving way, locking, those sorts of symptoms. These are the investigations that you would do. And then obviously the normal non-operative management of an arthritic joint or nerve and weight-bearing joint is the most appropriate. And then there are a number of things, if that fails and the patients are adequately, sufficiently symptomatic for, that you could do. But again, it's all around likely instability patients. Don't just do an operation that you know you can do. Work out what is there a problem with the joint that might have caused the arthritis in the first place. There is some evidence that just, and this is for the whole knee now as well, not just patellofemoral, but actually just, and it would be quite controversial because I'm sure the NHS won't want to pay for it, but an arthroscopic chondrectomy works better than a microfracture. Nick talked to you about cartilage last week. Did he talk about just chondrectomy? Was anyone here listening? No? Okay. So chondrectomy is a thing. You know, you can just do it. Stable edges and leave it. Don't do a microfracture. Microfracture is bad. If there's an anatomical abnormality that you can correct and there's some good cartilage you can load, like a high tibial osteotomy for tibiofemoral joint arthritis, maybe you can do that. And then you know, early active rehabilitation. So these are the sort of operations you might be considering. None of these are done commonly. Okay? This is quite unusual surgery for arthritis, other than maybe replacement for end-stage disease. You know, but there are some patients in whom maybe a tubercle osteotomy with slight medialization, anteromedialization might be appropriate. So it's, you know, this is different to instability patients. Okay? You're treating a patient who already has arthritis. So if you do an operation that can cause further arthritis in 10 years, but might relieve symptoms of that period of time, that's not the same as doing it in somebody with instability and no arthritis. It's the same thing as doing an osteotomy, high tibial osteotomy, someone with medial arthritis and overloading the lateral side. So you have to accept that you are overloading a bit of the other, a different bit of the joint. You probably need to do a soft tissue reconstruction as well. And so that's really what the Elmsley operation was all about. I really do it very rarely, but you know, there occasionally is a place for it. This was Chris Ackroyd doing it years ago. Great teacher, great surgeon, and he fixed those with 2 large fragment screws. So you can see quite a big. That's a big visualization. You know, we wouldn't be doing that anymore. And so there are, you know, some results. They're all quite historical, really, because there's not a lot of this happening other than in the States and Australia, and they don't publish their results on this, so we don't know what's happening. But some of the Europeans did. So you know, not bad results, not brilliant, but you know, they're okay. Don't do that. Keep coming back to it. Don't do it. It's terrible. So partial patellectomy or lateral facetectomy, as it's called. I think, you know, there is definitely a role for this. a lot of the Europeans are literally just doing a lateral facetectomy and not doing any realignment as well. I struggle to understand how that how that works. So if I do a lateral facetectomy, I will do a slight medialization and a lateral release and probably a medial reef as well. But the results of this are quite good, again, in the right patients. Some series less good. I've only done a few, but I think they do work quite well. So a young patient, maybe say this was a 40-year-old, this is the X-ray, an MRI shows reasonable medial cartilage. So here we are. You've got some good medial cartilage. You've got the osteophytes and overhang. I think this works quite well. But so Seb Parat would just chop that off and leave it. In Marseille, they say that works really well. I'm not sure how that can be the case. So I would medialize it as well. And that's how I would do it. But you've got to take a lot of the lateral facet. Okay? This isn't just a nibble of the osteophyte. This is a proper partial lateral facetectomy. Maybe 40% of the lateral facet. Otherwise, it's not going to work. So you've got to be quite aggressive, and obviously don't use a saw and saw beyond the patella down into here. That's not good. So saw maybe saw to here and then crack it with an osteotome. That's the best way to do that. Lateral release. Anyone here done an isolated lateral release ever? Good. So don't do that. That's all to say about that. They don't work. Okay, we don't do lateral releases anymore. And then total knee replacement or patellofemoral replacement. I think there is patellofemoral replacements do work well in the right patients. And the standard indication when it started in Bristol was severe arthritis in elderly patients. Don't do it for these sorts of things. Patients with patellofemoral pain syndrome. This thing down here, that's the result of a rather overly aggressive tubular osteotomy and a Rube Goldthwait actually originally. But it's not an operation for those sorts of problems. I think for Alta though, you can. I would, with true arthritis and Alta, I would do a tubular osteotomy and put the patella at the right height at the same time as doing a patellofemoral replacement. That's very controversial. A lot of the other surgeons doing this sort of stuff wouldn't do that, but I think it's logical and it works well. So that's why I do that. So it is a slightly smaller operation than a total knee replacement, although I don't think that I would subscribe to the fact that it's a quicker rehab or an easier rehab really. In elderly patients, maybe it's a little easier. It's borderline, but I think there is a lower physiological insult in the patient. Certainly a lower infection rate, lower risk of DVT and death. Certainly in young patients with end-stage degenerative disease, it works well. Post-trauma, it's not so good, but it's better than doing nothing if the patients really can't cope. And post-patellofemoral, just replacing the trochlea, again, is okay as long as you deal with the persistent instability of the extensor mechanism, which inevitably will be there. So just as one case example, this is someone I treated quite a long time ago actually. So she was a staff nurse. She was the main breadwinner for the family. She had a lifetime of anterior knee problems, all of them, none of it well treated. And by the age of 37, she'd been off work for 6 months, wasn't managing, couldn't look after the kids. Life was miserable for her. And she was joint lax, she hyperextended, the knee was in pretty poor state, quads disappeared. There wasn't a fusion, strangely, but she clearly had patellofemoral instability, which hadn't been treated well. And that's actually her X-ray, the one that I told you I might do a tubular osteotomy and medialization on. But she was really, I think beyond that, and I'm not sure that another operation that might have worked for a few years would have done the trick for her. So we had a long debate about it, and we did end up doing that. And she went back to full-time work. She's back to being the breadwinner. I see her in the clinic occasionally, and it's worked well for her. And so I think we don't know how long it's going to last, obviously, but for now, it's transformed her life back to being a full-time nurse and mum. And then this was an interesting lady who had had a medial uni by John Dixon in Weston. She was really active, loved her badminton, and then she'd begun to get anterior knee pain, quite unlucky with a medial uni, so it's very unusual. Had an injection, didn't really work, x-rays looked okay. She then had a scope. She wanted to return to badminton. She had a scope. So the knee looked all right. Patellofemoral joint was knackered. Scope showed bone-on-bone patellofemoral arthritis. Had a chondrectomy, it didn't really work. So she actually came and told me that what she wanted was patellofemoral replacement because she wanted to keep her ACL and play badminton. So we did one, and she did remarkably well actually. So bicompartmental procedures do well as well. Obviously, this is again quite controversial. You need to be careful, and this is why you need to be careful. So the joint registry now, as you'll be aware, record all of our operations and how well they do only in terms of survival, not in terms of function or patient satisfaction, or indeed actually whether the actual replacement works well or not, but just survival in terms of reoperation. And PAPFEMs and unis don't last as well as total knee replacements. So that's well established. There are lots of good reasons why that is. One of the major reasons is that if patients with a painful joint replacement are seen in a knee clinic of a revision knee surgeon, they've got 7 times the chance of being revised with exactly the same knee scores if they've got a partial knee replacement compared with a total knee replacement, because it's easy to do. And probably the revision surgeon doesn't believe in partial knee replacements. So that's one of the major reasons. But you can't blame it all on that. There are other reasons for failure. One of the other things is that in patients having a partial replacement, they tend to be the younger age groups, and you can see that on here, this is total knees at different ages, and certainly the under 55s fail much more quickly than the over 80s. So again, these things all add up to showing that you'd expect a higher revision rate, and you do have a higher revision rate, but as long as your revision rate for unis or patellofemorals is the expected rate, and as long as you're doing enough all of knee surgery, you won't become an outlier. And this is quite interesting. If you break down the patellofemorals by age, the over 75s and the under 50s do survive longer than the middle groups decades. And I think that's because those two groups, the older and the very young, the older don't have time to get disease progression, and the younger ones have severe dysplasia and so don't have any reason to get disease progression. Whereas, say, the 60s, 75s probably have primary arthritis that first affects the knee replacement, and then it just progresses on. So patellofemoral arthritis is a different beast if it's primary disease, and it probably does progress through the knee joint. So the very young and the very old. So that's my NJR figures at the minute, and so as long as you're doing lots of these things, they do quite well. If you don't do very many, they don't do very well. So the key is do lots of it. And I think if you are going to do patellofemoral replacements, well, you need to do them in a unit where they do lots. Don't do them in a place where they don't. And do them in young patients with dysplasia, elderly patients. And then if you're doing the other lot, I have a contract with these patients that says we are going to need further surgery in the future. If you need further surgery, have it done by somebody who does partial replacements, doesn't matter who it is, as long as they do lots of partials, and think about having adding in another compartmental replacement rather than changing it to a total knee replacement. It still counts as a revision on the NJR, so it doesn't help your figures, but it's better for the patient and it'll function better still, which is the reason that you did a compartmental replacement in the first place. And we'll only do it if you accept and expect that you will need further surgery at some point. If you want to just have one operation, go away and accept that you've got a higher risk of pain and stiffness, then we'll do a total knee. So for people who believe in patellofemoral problems and sorting them out, I think these sorts of things should be done only by people doing lots of this sort of stuff. Again, doesn't matter where it is, as long as it's done frequently. Severe dysplasia, a combination of problems in joint hypermobility, they're quite tricky. And then for the replacements, I think FEMs and bicompartmentals do need to be done in units, doing lots of these sorts of surgeries. I think that was an advert for a beanbag in Amsterdam Airport in a hash load, but it looks like a patella with avulsion fragment. They've all got any questions? Nothing at all. How about the streamers? Can they contact you? Email questions?
Yeah, we can ask them.
Is anyone on?
Yeah, a couple of them.
Yeah.
If you're doing an MPFL reconstruction and the patella alta,
yeah.
Then do you have to address both things, or otherwise, the risk of them wanting the reconstruction would be higher?
Exactly right. So
you wouldn't just do it in isolation?
I wouldn't. No. So I used to years ago, and then as I've understood this more, I correct it. Whatever I'm doing, if patella alta coexists with the problem, I deal with the patella alta as well. So a trochleoplasty, an MPFL reconstruction, a patellofemoral replacement. If there's patella alta, I'll lower the patella to correct safety.
And the other one was about the patellofemoral joint replacements. You said you do it in young people with dysplasia, so
and with arthritis. Yeah.
So do you have to do anything when you're seating down that?
Trochlear.
Do you have to do a trochleoplasty?
Yeah, no. So the implant is the trochleoplasty. So you're giving them a normal shaped trochlea where previously they had dysplasia. So the important thing with that is the design and philosophy of the patellofemoral replacement that you're using. So there are two pathways to go down with patellofemoral replacement. One is an inlay component, which is guided by the natural anatomy. And the other is an onlay component, which is totally flexible. And if you're treating patients with dysplasia, my view is that you have to have an onlay component, not an inlay one that lays within the natural anatomy of the patient. So there are surgeons who use inlays, but if you look, I can't do your whole thing on patellofemoral replacement, but the survival rates for inlay components is much worse, and the risk of persistent malalignment, maltracking, and early wear is very high with inlays, whereas with onlays, it's about 2% now, or less. So you have to use the right implant, the right surgical technique, and then it'll work.
Do you address the patella alta if they have it at the same time, or
same time, all in one go? Yeah, because for instance, if you're doing an MPFL reconstruction and you put it in with patella high and then you lower the patella, then the tension in the ligament is all wrong, or the length, not the tension, the length, because it's not under tension, it's a check rate. There's one of the things about doing an MPFL reconstruction is people in the meetings all talk about what position to put them in to tension the graft. You shouldn't be tensioning the graft. You should be looking from above, superlateral portal, and putting the graft in at the length that gives you a patella sitting centrally in the groove throughout range, because it's an isometric graft that you put in. So there's no tensioning, it's just putting the correct length. And very often what you see is you start on, there's that image I showed you before the MPFL and after, and literally you just pass the ligament into the tunnels and not tighten it on. Just the fact that it's sitting there centralizes the patella. Literally that, there's no tension. It's very easy to over tighten, and that causes pain, stiffness, and probably arthritis later on. So that's why the superlateral portal is so important. You see subtle changes make a big difference to where the patella sits.
When you do MPFLs, do you need to deflate the tourniquet when you're assessing the tracking?
I don't know. I don't deflate the tourniquet, and because it's a passive movement, I'm not sure that deflating the tourniquet will make a difference. If you could do an active assessment, then obviously it would be better. But it's all passive. We've done Damon Clark's thesis was all on patellofemoral instability, and he worked out a way of measuring the congruity of the patellofemoral joint from MRI scans, and we looked at that before and after surgery, and using the techniques that I knew, the congruity that we thought was achieved at the time of surgery persists in patients awake and actively moving their joints with MPFLs and Trocker plasters. So it seems to work. Anything else? Oh, it's 3:30. Should we have some tea? And then Honor will come and present her knee to us. Is there tea outside? Or
yeah, some coffee just outside.
Right. Do you want to do that, or do you want to carry on your quick break? I just want people to have an understanding of the lack of understanding and what else.
I looked at the rotor this morning. There's almost no temperature. It's on
yeah, so it's not loading. It's done through this Medi rotor app.
There's a website.
Yeah.
Yeah,
no, I know how it's, yeah, because I viewed it through the app.
Yeah, I was just told to do
Like the day of the week. Like it was at mean time the AM or something, which is 8 and it means March to.
What year is it?
To make your own class.
Yeah.
And we don't have lots of patients.
So I just need a few for the
might increase the functional
yeah, just what it roughly is your AM, your AM.
social Saturday.
And then you got the option here to do it again. You can just do it, but yeah, I thought it was quite. Yeah, you can import the shit. I haven't quite worked out that there's an online.
Yeah, so I didn't answer all of
That was just merely the sort of. I'm doing sure. It's just I don't know.
So what conditions?
Or whatever. It's just, you know, very.
I don't know, but yours was actually problem.
Yeah.
So then it's small, so you know, it doesn't-
I tell you what, you don't know how much,
Because
you know,
I'm-
by the time it
Check the
was.
space, so you just want to shortly emphasize on the risk of
Yeah.
You can get a, I mean, if we go through this, it's actually really good.
Anyway, it's very good.
Do you mind if I send you a, thing on ICP?
Yes, of course, yeah.
This is great.
Yeah.
It's, yeah, no, it's interesting, so what's this like as a sort of.
Oh, you was there?
Yeah.
Oh, fantastic.
So, he does a, yes, he does a lot.
Yeah.
Yeah.
So.
Quite nice to-
Yeah, thank you, is the thing.
He's a good lad. He did a lot.
I think I can share it. Share around that space.
I'm not sure he sees it like that. Of course he doesn't, that's why he went, obviously. He can go because he had to, he won't have a choice, yeah. Yeah.
I just did this with
Yeah, no.
Yeah. How are you? Yeah, good, thank you.
Are you back in town? No,
Yeah, I'm doing exam, yes.
Yeah.
November exam. And then, yeah, maybe November written exam in February. I was gonna ask you actually, what's your advice for people coming up to exam? That, because your stuff, like I said, I mean, you go to conferences and people will still be saying, you need to do a natural release, or you need to do a media
Yes, I know.
tip top.
Yeah.
Whereas, and that's what I'm worried about. So I will say.
Yeah, that is the issue. So what I would say, you can say, you've worked with me,
Yeah.
and this is what you've been taught, and that's fine.
I think the nice thing is you have published all of your series.
You can also say if you want, this is the mainstream view on this, or this is what I think most of certain countries might consider, but I would be more likely to do this, and this is why. And no one is going to fail. You could just say, I do a natural release, and cheap visualization, and just pass it down.
Yeah.
But, it's a bit disappointing.
It is. I know. There's a part of me that says, I know I'm not supposed to pick a fight with the examiner, but actually.
And so you don't. So you say,
Yeah.
I think this is what most people would do. I've worked in centre editing because they're interested in it and they published a lot on it, and this is what they would do.
Yeah, because it's a very.
That's a perfect reasonable. Yes.
That's fair, yeah. I mean, having worked with you 6 months, this is, I can roll because it is so formulaic and so well thought out and planned that it's really.
And published, and the
Yeah.
results, the
Yeah,
series and
yeah.
all of it is published. So you can't be wrong.
Yeah. That's very good.
How do you make?
I'm very good.
Stuff is all right in the,
You're pretty good.
almost as well as the Australians.
It's really easy.
That was,
That's really annihilated.
I sent my cousins the video of Steve Smith crying after,
Did you cry?
well, the thing is, so no, it was after the, where was it? It was after the the ball tampering thing, you got busted.
Yeah.
Do you remember that? But actually, if you, do you know, he bowled one over.
Yeah.
Like 25.
Yeah.
It fits perfectly. Look what happened. Just think about it.
Good both. This is the first time I've ever done anything.
This is the first time I bowled. It was glorious. It was My parents been trying to see, like, it's one of those things where,
Australia, they actually didn't do too badly considering they
Basically, you're on that. What's how come Taunton are struggling for cover this Saturday then?
Which one's off?
Let's see. Why they can't get no journalists around.
Yeah. Which one is off? Yeah, let's get these on a quick chat to avoid that side, mate. Just-
Yeah, that's fine. Yeah.
Yeah. Last name touches.
I don't just do it, right? It's just.
I didn't realise that it was supposed to be just like a signage, but it's fine. I was up really late. I started my boss was going on holiday for 2 weeks, so I needed him to sign off my clinical supervisor report at like 10 WBAs this morning. So I had to actually blitz through a bunch last night. So I'm just like a bit late on this one.
I just think you just want to do it.
Yeah. I mean, I've only got like 7 slides. I've not done it anywhere near.
No, I think even small is way more important.
Yeah, I mean, to be fair, it's quite a good idea in that if he ever has to do a teaching on it again, it's not a presentation ready, mate.
Yes, they come in very handy actually. Well, and they're nice.
pretty good this week, so you've got time. Yeah, I've got sort of leave, but I'm just smashing through some other revision and stuff. So. So next week I've got a meeting Friday morning.
Are we next week? 15th?
Yeah, so I can meet you any time next week, really.
So next week, I'm booked. Bit of a crazy week.
Yeah, I think I remember saying, I said to you that I've got it fairly free, but you've got quite a lot.
Depends, if JK comes back, then I might be having some time in the mornings.
Which morning? Monday, Tuesday?
Yeah.
And when will you know? Monday, Tuesday?
Equally, the bosses will set me into registrar duties at the moment. We're doubling up in the afternoon clinics and things later on. We could definitely do some after work stuff. That was, I know you agree with us in daytime.
Yeah. Well, we could do Wednesday evening. You got the list on Wednesday.
I've got a multiple list.
So I'm on call just during the day, so I'll hand over to who's on call kids-wise Wednesday. Chris.
No,
So I'll be handing over to Andy. I think I've got a list in the afternoon, and I'm doing a chart humorous. So once that's finished, then I can hand over to Andy and then
Wednesday 17th.
Wednesday 17th in the evening.
Then as a hopeful.
Down on the boundary.
Yeah.
Is is on the following week.
Use the one.
Yeah.
Who's doing your money? Go, right, we'll leave with him now.
So we meeting that Friday morning. That's the 19th.
I will have done the night shift.
Yeah, I remember you said you were doing the night shift, you were going to do a handover, and then you were going to go, and then I said, are you sure you want to hang around for the mock? Because the mock's pushed in at the Royal BRI, so instead of you going home and coming back,
Yeah, so I will hang around.
we were just going to work until the 5.
Yeah.
Because I'm free that morning, so I can just work.
Let's do it. And then I'll do the first hour of Bible and
Yeah, well, I think that's fair enough. And then you're on night. Yes, that was the other thing. Then you're on nights that night.
Yeah. So I'm going home that after Bible, Harry's birthday trampoline party. Then I'm coming back for the night shift. And then I'm going home Saturday morning because a proper party with those people into a barbecue Saturday evening.
So then you're coming back in for your
No,
night.
James is doing my night shift.
Okay, all right.
And then I'm going to do the whole of Sunday.
The whole of Sunday, overnight. Yeah, because then I'm meeting you for revision then, or you, that was the other one then,
On the Monday.
on the Monday.
So that kind of works out. So that would be the,
Because it'll be post-call on the 22nd.
Yeah.
Do the handover, and then we go upstairs and do some.
yeah, that's it.
Release.
So we'll do the whole morning.
Well, until, that may be flexible just because we've got lots of upland trauma that I may be reluctant to starting early, and Stephen has just got nothing, then I'll go and do some clavicles and stuff.
You being put that in that so don't know.
Well, I mean, the lateral, certainly lateral clavicles I can do. I'm doing a shaft humerus on Wednesday. I did say I'd do it on my, like, said, well, I'm happy to do it on my own, but I really want an assistant, because what happens is you say to me, oh, I'll do that, and then you're on your own. And even getting an SHO is just not quite, it's not great.
So we've got Monday,
Wednesday,
and then Wednesday 24th,
in the morning,
and then I'm away on campus for all the kids.
very nice. Yeah, and I'm away that week. And then the following week, now, that Monday, I'm free all day now.
I am on call.
Okay.
Yeah, I'm on Thursday.
Yeah, no, we've got it again, and I'm coming to you. My only issue is that we're doing this really cool biceps reconstruction with ruin as a combined case on Thursday.
Okay.
So that's why I was hoping that if you were free on the Monday, then through to you then.
That's quite well. If JK is back to do a bit more, I would love to my
Yeah.
and we'll do something interesting together.
Well, you know, I can do something in Bristol Thursday morning.
Oh, yes, I'm just on Monday, sorry.
On the Monday, yeah.
Cool. So we can.
And then on the Thursday, are you, well, you can say no, it's not, it's absolutely fine. We can go, yeah.
Shit, it is like, rather confused revisions and.
Yeah, I'm sorry, mate, I know, I will come through to that, I promise.
You can tolerate me.
Can I see the ASCP? Did they sell it for all
But I'll
Yeah, yes, I'll take it.
So if I change
That's the
that
same.
Thursday to 9 o'clock
And they wanted you to send it to them.
at mine.
Yeah, so I emailed her, like Clay, or her day after she
Your
was
case goes down.
in June, and then they said, oh, you have to submit it within a month of your RCP, so I just sent it today to be like, sorry, I said it's too early, she's like, I've already got this for you, like, just email me saying I have to submit it within a, and then this is my form I've started doing during that talk. So she's had a problem again, she's got
And then, potentially Monday,
like
29 means, you say you, if JK's back,
I was gonna
she'll be back, right?
If he's back and doing 60, he doesn't need to be supernumerary, I will give him my hot notes. I've done far too many things.
Yeah, I didn't know that type of counted, there's actually in the BORG section, but symptomatic. I first had to have one yesterday.
I did it on angle, but I don't.
Well, it says here electron patella, but I don't know. My nails.
Burn that up on today.
And then full it's heavy records.
Well, I'm free all day, so yeah, would you, you're on call, aren't you? So I can come to it comes to the VR.
Well, I mean, it's trauma is doing it.
Yeah, so purely because and one day
If it's carried the whole about heavy loss in 30. About 60, 70.
Oh, right, yeah. And then we change over, I've got annual leave Monday, so she's still sick, it's on internet.
I have got annual leave.
I can go through one and I can do two.
Yeah.
Yeah, I'll show you I think, yeah. I mean, the only ones that sign me off for when they're actually on scrubs.
One on that, and then
Yeah. I've only got one. I've got one thing to write for Take the line was like, so.
today, we're inside.
That's a good point, it's 25th June, wasn't it? So they probably can't go
Just to get private. What do you mean, are you going with the headline?
Oh, I forgot your drag act. Inyana.
Yeah.
Got it, got it.
I'm not expecting my gender. That's like a legit reckon. Just because you're they're not really like I think probably does.
Just been set my
The 26th of July.
Yours,
Yeah.
Oh, really?
Review 4 hours.
if they start sharpening me, but they just like that, just keep throwing work at you. What's up?
That's Charlie, you're very, very helpful. That is because it's not fucking reduced and not properly, and the place is not properly.
So it doesn't say on here, so you now need three level fours for the procedures.
But you tell me, you tell me what they
You
say.
need 3.
Like,
Yeah, they changed it.
and every
Which one was separate now? They went by this. So this is what's changed.
Interesting.
Two different.
They're not always the same.
Somewhere here, just updated here. This is the updated guidelines.
Is that-
So they didn't hold, like, they, what's holding them up?
Updated Fridays were.
Is hopes and dreams.
That's good run.
And then
Yeah, so I mean, they
said.
yeah, but they changed the refund. I mean, what you got, one, maybe, hopefully they got two screws in there.
Yeah, it's a long way.
That's just be like, right, this
No, they got it in, but it's a shell.
Not a
So it's all it's done is it's just
They've
they've used the wrong thing, they just done it.
20 scopes, max.
I know it wasn't me.
Header of control, changed it.
So yeah, what was it?
Okay, but the pool. What now? Yeah, the pool.
Patellofemoral shaft gets second as the
Very,
next
very hard.
Is it not? Compression history.
This is long sick.
Okay.
No amount of true lateral.
Plate fixation on any fracture or. I've got loads I really realised that. I don't know whether that's an office or a
There's a reason for this. You guys can still send it out by email.
I thought this is what you had.
Watch the space. I need to get Fosse to upload all the material from this term, so it should be on the website and links to streams.
But it can also be outrun to record and come back.
Yeah, it seems like quite a nice Adam gave me the tour. Adam Smith gave me the tour when I came out on Monday. Yeah, it seems quite nice. Show me swimming pool.
I've never been there. I never really been using
Yeah. Who Adam?
Okay, guys. So we got the second two natural history talk. So we've heard so far that instability is associated with arthritis left untreated. MPFL reconstruction might be some evidence it's protective for a period of time. And then we're now going to hear if there's any evidence on, well, I showed you two papers on tibial tubular osteotomy, tib club osteotomy and trocheoplasty. Rob.
Sure. So Ian talked through the reasons for doing it, the logic behind it. So I'll just debunked a couple of the controversies. So just quick about trocheoplasty as well. Dujour wrote one of his papers, the ideal indication for it being for those two types of trochlear dysplasia in order to deepen the sulcus and restore normal biomechanics. By and large, they've got a good satisfaction rate post-op, and having pre-existing OA is contraindication. That's the type of procedure that we do for Bristol, is that right? Yeah. The 3-mil bifold, where it's lifted up, you undermine the bone, and then put it down into a new groove. So the three main kind of papers that I found was the one from Bristol, which is the 11-year follow-up paper with 214 patients. 39 of them had x-rays past 5 years. So of all the papers that I could find out there, very few of them actually demonstrated long-term outcomes past 5-10 years, where there was a radiographic OA at that point. So the progression of OA, even though they sound not that much, is in quite a short space of time, and the mean age of these patients tends to be quite young as well. So, like we talked about, they are done in patients without established OA. So mean age in the range of in their 20s. And then this one was a different 15-year post-op follow-up paper that I could find, which was probably the longest. They used a different technique to the one used in Bristol, the mass technique. Now, that works in a similar kind of way in that they take off the chondral surface to get rid of the bone underneath to make space. But then what they do is they hammer down the cartilage surface into the newly formed groove to make it fit. So, unsurprisingly, they've got quite worse arthritic outcomes. So I suspect technique is a big part of that. That's using the Iwano grading of OA, and that's their outcomes there. You can see it goes from being not too bad pre-op to the opposite at follow-up. And their mean follow-up was pretty good, actually. It was 15 years. The final paper was a systematic review of the available literature, 2018 paper, which included 998 patients in 21 studies. They showed that all the studies out there are not very good in terms of their hierarchy of evidence. No RCTs looking into outcomes, and significant heterogeneity in the studies out there. Overall, they showed that there are good clinical outcomes with the tropicoplasty, but the rates of OA itself is highly variable. So this was the summary of their papers that they included for OA, that included OA as an outcome. I don't know if you can read it, but essentially it kind of varies from nothing up to the paper that I just showed you, which was 33 out of 34. And their mean follow-up as well is not that long really, it's kind of less than 3 years. So to get evidence of OA in, a third of patients with a mean follow-up of like 4 or 5 years, it demonstrates quite it's not a benign procedure like I started talking about. And then a similar kind of thing runs with tibial tubercle osteotomy. So we talked about the indications, including controversy about the TTTG offset being an indication for medializing, but with distalizing as a good option for patella alta. Using a superlateral portal for arthroscopic assessment in helping you in patients who only have closed physes. This isn't a benign procedure either, like we talked about earlier on. In one paper, they had a fifth of patients requiring hardware removal. In fact, I think that was cumulative outcomes of one paper, which one study which looked at 21 papers. And overall, although outcomes were quite good, complications aren't insignificant. There were some nerve palsies there, some superficial wound breakdowns. Compartment syndrome wasn't as common as worried about, but the main thing being hardware irritation. And so these are the 3 kind of big ones that I found. And on the next slide, I've lifted the information from this that I just told already. But there was a literature review which I was talking about there. Again, in terms of level of evidence, most level, no RCTs again, looking at it compared to non-operative management. And also that literature review included all indications, so it wasn't just for dysplasia and instability, it also included about a third of the papers which had the osteotomy in isolation was done for OA, which did improve symptoms, but it wasn't what I was asked to look at. And something that's fairly clear, you can see in that bottom paper they had reasonable number of patients for severe recurrent instability, and they had progression in their OA at a mean follow-up rate of only 5 years. You've got 25% increased prevalence of patellofemoral OA in the space of 5 years. The Bristol paper from 2013, which looked at some longer-term outcomes, 4 and 12 years follow-up, which again showed that, it showed that if you have OA to start with, your OA gets worse. If you have no OA to start with, then you can do okay. And then there's those 2 papers at the bottom, one from 76. That was the Crosby and Insull paper, which was quoted. Now, that's not just looking at patients who have got closed physes. They did 27 out of 69 patients were under the age of 14. 5 of them progressed to retrovirus, and clearly the outcomes overall were not as good as the untreated cohort. That's a bunch of references. So in summary, they're not necessarily benign procedures as optimistic.
Brilliant. Thank you very much. So it looks like one is forgotten or has been waylaid. So we can do one of 2 things. I can either show you or ask one of you to examine one of your knees, and then do some clinical cases, or we can just do some clinical cases, or what do people want to do?
Do both.
Do both? Right. You've got pink trousers on, that's perfect. Will they roll up? Yeah. Excellent. Would you mind taking your shoes off and rolling up your trousers? Is that upsetting your personal space in any way?
Good question. What's the early stage, or how long do you wait from an age point of view before you do it? Are you waiting?
Trox is
you waiting for them to close their eyes?
Yeah, pretty much closed. I mean, I've done a 12-year-old girl, but she had closed physes. I've done a 14-year-old girl who just had slightly open physes.
Because that fear of.
Yeah, I don't want. Yeah, so in Norwich they've done. So Simon Donnell in Norwich has done a number of de jour technique troca classes in excluding de jour patients. I think that's a bad idea. And the same for tuberous osteotomy. You know, there or thereabouts. And the tibial physis, apophysis, tubular apophysis closes sooner than the main physis. So you can get away with that reasonably young, but you really don't want to use artery, which is what you said about that. So quickly, guys. So this is just a very quick run at how I would screen and look at a knee in clinic. So you've got a kneecap that's dislocated twice. Otherwise, between dislocations, it's not too bad. It swells a bit at the time, then you rehab in time, but you can't manage to get back to sport. So what can we see? So joint laxity. I'm not going to do the basic. You all know the basic scores: thumb, little finger, elbows, knees, touch the floor, flat your hands. So then overall limb alignment. What do you think about the overall limb alignment?
I think he looks pretty straight.
Does he?
Can you bring your feet slightly? Maybe a touch of those.
You can't tell with baggy trousers on. You'd like him to be less stressed.
Make it from the waist down. Right. Okay.
Make sure
Straight.
you focus that.
Yeah, I think straight.
A bit nervous. Together. Ferrous. Okay, feet slightly apart again, some shoulder height. Feet, hind foot. You turn around.
It's good.
Not bad. Stand up onto your toes. Good arches, so he's not got any major hind foot, abnormalities. Probably slightly pes planus, but not major. And then just stand side on, just legs straight. Any recurvatum or any problems? No. So, and then no surgical scars, we'll assume. No muscle wasting. Nothing else that is alarming. Okay. No muscle wasting. Okay. So I'm just probably
breaks on.
The patient say you need to stand up again. So there's it's amazing how many people can't do that. Okay, so just come and see yourself on is it safe? Yeah, so just sit. So legs hanging down. So in terms of looking for patella height, if you put your index finger on the top of the lateral tibial plateau into the soft spot there, generally the distal pole of the patella will be hovering around the top part of your finger. If it's like this, and the patella's here, or if when they're sitting, so you've got slightly high kneecaps, right? So if your kneecaps sitting, instead of facing forwards, they're facing upwards or up here, then maybe there's some patella alpha going on there. Do you get any knee pain? So that's looking at patella height, and then just straighten your leg up. So normal knee first, then the bad knee, and I'm literally just feeling, finger either side of the patella and feeling what it's done. So this is coming up totally straight, and then yours is slightly going off laterally as you fully extend. So you're slightly disengaging and slightly subluxing because you've got a slightly high kneecap. But it doesn't hurt you, so we won't worry about it. And then we can look at 5 foot angle, so foot up to 90, knee at 90, angle between the thigh and the foot, and you're absolutely plumb straight. Okay, so usually about 20 to 30 degrees of external tibial torsion is what you'd see. You very rarely see internal torsion, but some people will have it. And then what's abnormal, I don't know, but just have a look at it, see what, if it's terribly abnormal, you probably need to do something about it. And then I think it's okay as a screening test just to rotate the hip like this and this seated. And if it does this, which is it's totally symmetrical, it's highly unlikely if you put them prone, it'll be abnormal. But in the exam, put them prone and move the hips internally and externally, and make sure you get it the right way around. Okay, so legs going out to the side is internal rotation, not the other way around. Okay. So, but I think in clinic, it's fine to do that. And unless you find something grossly abnormal, you're not going to gain anything further by putting the patient prone. So that's really mostly it. And then if you just sit yourself back there, then obviously you've got to just check all the other things. So looks for hyperextension. There isn't any, so it's neutral inflection depending on how far it goes. So that's normal degree of flexion. It's about 145 degrees. And then ligaments. So I just examine ligaments, just basically medial. Is that hand here and there, back and forth. ACL, so Lachman, you can do this. You can feel the clump there. Pivot shift. So this is how I do pivot shift. Just cut the heel in palm of your hand. Flat of your hand behind the fibular head, and just gently bend the knee up. So you're accelerating the knee with this hand towards the ceiling. That internally rotates the tibia on the femur. And if there's a pivot shift, it'll rock back and forth like that. You've got a very slight rock. Nothing major. So that's the ACL. PCL, obviously, either a sag, feel for the step off, posterior jaw. And then if you're worried about post-lateral corner, then you're going to do your external dial test and things like that, and a posterior jaw at 30. And then I do just bend the hip up here and do another, just check it doesn't hurt in these positions. Make sure there's nothing else going on there, and an extension there and there. Feel for pulses, feel for neurological numbness, weakness, those things. And that, that's really, it's very straightforward. There's nothing magical about it. Does anyone have any questions? Didn't look at foot progression angle actually when you were standing, but you were straight. So.
You talk about patellar apprehension.
Yes, sorry, yes, you're quite right. So yeah, just pop yourself back around here. So the patellar height, and then a lot of patients literally can't just extend their knees. If they can, but they're worried. So a positive patellar apprehension test is if you put lateral pressure on the patella, and then ask the patient to extend, and they can't do it. Not that they don't like it very much. That's not positive. It's that they can't do it. It stops from doing it by me pushing laterally. So that's the patellar apprehension test, proper one. Yeah.
Do you then, is it a bit like the shoulder apprehension where you push medially, they can do it, or are they just
that's not part of it. I suppose that would help you to decide, are they not doing it because you're pushing the knee out, or just because they don't like you fiddling with it?
It's not something you do.
No, it's not. No. It's a good point, I might try it.
Yes.
Great, so very straightforward. The knee examination is, it's not difficult. Right, where are we? We'll stick that.
I've got my, sorry, yeah.
Sorry, I'm sorry. So I'll just show you some cases, guys. Whenever you want to stand up and leave, then we'll all stand up and leave.
Yeah, that will come in
Right, that's what the Avon Orthopedic Centre used to look like, and I believe we're going to build a new one. Isn't that great? History will repeat itself. So I've got a number of cases here. We'll just rattle through them until you get bored. So 30-year-old, again, lifelong patellofemoral problems, dislocations from the age of 12, had a lateral release at 18, which stopped the dislocations, basically. And then a recent history from early 20s, increasing pain, swelling, and instability, and now, as they all are, significantly disabled. So that's the examination. So clinical patella alta, bit of an effusion, and some clear instability in examining the no torsional problems. So these are the X-rays and the MRI scans. We start front left and work our way along the road. Can you see?
So the MRI, as you explained, does show degree of patella alta on the surgical slice. The access slices do show quite a shallow, probably concave trochlea, and obviously that lateral patella tilt. I'm not sure what the X-rays at the bottom are showing. It might be saying the X-ray.
Well, they're showing you, I mean, on the lateral X-ray, you can see that you've got bone on bone patellofemoral arthritis. Lateral X-ray is always the most useful.
Yeah. So if you've already got established degenerative changes in the patellofemoral joint, then that probably changes your algorithm, changes your treatment options. So you start off with non-operative treatments, go through the range of analgesia, physio, as much as you can. She'll probably do through that.
Yeah.
She was in your clinic, and then I guess your options for treating her at this stage probably switch to the non-sexual arthritis, the degenerative EFJ sort of pathway.
Yeah.
Don't know what the role would be, if any, of doing severe cervical short sleep if you've already got established changes. And whether or not potentially you might be thinking of arthritis, but she's very young.
Yeah.
She's very young.
Right. So you've got do nothing, tubal osteotomy. What would you do with tubal osteotomy?
You would, according to what we heard today, you would only really distalize it if you were concerned.
Well, so with arthritis, I'm happy to do a bit of a medialization, accepting that 10 years afterwards you're likely to have called medial patellofemoral arthritis.
Yeah.
Inflection.
But obviously with the trochlear morphology the way it is, you'd have to try and assess and correct for that as well. So I think that's probably quite a few things in one go, which may not necessarily improve symptoms. I'm guessing you'd also want to scope from me as well, just so you can assess actually what you're doing, because this is not a straightforward case.
Yeah. Okay, so I did scope it just to see what the pattern of arthritis was like. It was totally, the patella was totally gone, all bone. No good bone, no good cartilage. So the options are do nothing, or so I scoped it with a view to doing tubal osteotomy. There's nothing to load, nothing good to load, so I failed. So then we're doing nothing, or a patellofemoral replacement, or a total replacement. Is that right?
Yeah, did you say total?
Well, that's what. If the majority of surgeons across the country were going to do anything surgical, replacement-wise, especially do a total knee replacement.
Yeah, or they will refer to someone who's very capable of doing.
Well, they might do it. They might just do a total knee replacement. So sadly, what still happens across the country. Yeah. So that's right. So if you were going to do a patellofemoral replacement, what would you consent? How would your consent process go?
So I would explain to them what the purpose of the patellofemoral was. Explain to what the principle procedure are. Explain to them the primary benefit of the procedure is pain relief. I'll explain to them what the risks are of this. I think the most important risks of this would be disease progression, or the specific risks with this would be disease progression. We may have to think about, well, I don't know if there are any additional procedures you could do intraoperatively in order to try and change alignment or change the position where you place your components. I think disease progression is the main thing. Essentially, you're trying to buy them time, so this is not just a procedure that's going to last them however many years, but it's going to buy them some time and hopefully give them some return to function alongside with other usual risks of arthritis.
Okay. So would you tell her how long it can last?
I probably would not, only because I don't know the data to suggest patellofemoral joints in this particular age group for this particular pattern of disease. I think
We don't have any idea at all. So I can do that. And we'll see. So here we are. Next one along. So 60-year-old pharmacist, active, 10 years of anterior knee pain. It's got worse. Can't drive. A bit of instability by the sounds of things. And she gets worse with exercise and her physios. So she's got patella alta. Can't do the straight leg raise based on here. She's got the fusion. Right. It's not that common to have fusion in these actually, but so those are her X-rays in a 60-year-old.
So she's got bone-on-bone arthritis, PFJ with lateralization of patella. Can't really comment on these, what the medial facets looks like. So obviously start off with your conservative measures which she's tried, and if anything they've made it worse.
Okay. So what are we going to do?
I don't particularly think there's a role for soft tissue procedure here.
No.
Essentially, we're talking about anastomoral arthroplasty.
Yeah, I mean, you would want to discuss at least the possibility of a tube osteotomy. So as well as having arthritis, she's got significant patella alta.
Yeah.
You know, just from the X-ray. I don't think I've got any scans of this because we don't need them, but she's got significant alta as well. So it might be that distalizing, there might be a bit of good cartilage somewhere. You know, I think you want to discuss it at least.
So we do MRI.
Yeah, I think you want, if you were thinking of doing a tube osteotomy, so I wouldn't for this patient, but which is why I've got an MRI scan. But I think an exam answer would be you want a bit more information. Is there any decent cartilage there? Potentially a tubercle osteotomy, distalizing and slightly medializing, the lateral facetectomy and the lateral release medial repair. Might give us some relief, but she's 60, so you know we don't really do many realignments. Of, you know, would you do a high tibial osteotomy in a 6-year-old with bone on bone off? Well, some surgeons would actually, not many, I don't think. Some would. So we're at that stage where it's probably not. We're not looking at realignment, so we're looking at replacement. So would you do a total or a patellofemoral? Or?
So I've had a discussion with her. She's in that sort of middle ground age group where we know this age group of patients have a high revision rate because they're sort of not old enough to die before they get progression, but they have primary osteoarthritis. Well, it does sound like she's had a background of problems for years. So
she's got out.
Yeah. So explain to her that a PFJ, isolated PFJ replacement does have a higher revision rate, but it's potentially slightly smaller surgery. It retains some of the normal mechanics of the knee, and she'll probably get better function for the time that it's working. If she can have a total knee replacement, which we know is a very reliable procedure, has a lower revision rate, but potentially slightly less good function in the early years. And if she's willing to accept the revision rate and do a PFJ replacement.
Any technical issues do you think you might have with either a total or a patellofemoral replacement in terms of the patella?
On the lateral, the patella itself is very concave, quite thin. I don't know if bones looked on there. On the skyline views, it actually doesn't look too bad.
Well, you've got a lot of bone loss under here.
Yeah.
So this is medial facet, and you've got a big defect here. But it will be, in fact, a contained defect. So your patella cup would be aiming to be across to about here, and then you'll have a contained defect here. So a lot of people get a bit agitated about patellae that look like this, but actually you can resurface them quite well, excepting that you've got a contained defect, which you drill and fill this.
But do you need to know anything about the alta revision?
Yes. So that's a good question. So I actually didn't. But I did these quite a long time ago, and now I would. She's actually fine, she doesn't have any instability, but I still think that the load on the articulation is quite high in the early stages. The avon's quite long, so it does lengthen the trochlea from what her native trochlea looked like. So she's less outer than she was with her native trochlea, but she's still outer. And yeah, nowadays I would do that. You can see on those APs, particularly this one, she looks slightly laterally subluxed. She's going to hit it.
What would you do now?
I would do a tube colonoscopy with the patellofemoral replacement. Yeah. Okay, so then there's a couple of these. I saw all of these in the last couple of weeks. Not those first two, but so this is a 14-year-old. Dancer cheerleader, she's miserable. Recurrent dislocations of her patellae. She's not failed. So she's a little bit mobile. She's got moderate femoral torsion, which you can see on that AP X-ray. So you know what I was talking about torsion. So true AP of the tibia, slightly oblique view of the femur. So she's got some torsion, and that's confirmed. That's what we found examining her. Terrible patellar apprehension. She won't let you anywhere near her knee. Actually, you can't touch it. Clinically normal height, and her patellae come off into extension. And those are the scans. So what we've got here.
So on the radiograph and the MRI scan, she's got trochlear dysplasia with a.
Good. So just tell me what you saw on the radiograph.
In terms of the crossover sign on the lateral.
Yes. So she has got a crossing sign. It's not dreadful, is it? And it's quite proximal. So on the de jour classification, the severe ones, B's and D's, usually cross down here, and they have a falaise, a cliff edge. And here she's crossing up here. So you wouldn't necessarily think it's going to be severe. But you're quite right, there's a sign that there's some dysplasia there, some sign of torsion, and then that's your axial
The axial is complex.
She's got a huge dome. Yeah. Healthy cartilage, as far as you can tell. It's healthy. Yeah. I'm sorry about the images, I just took pictures of these on my phone while I was doing them all the last couple of weeks for this talk, so they're not the best. But. And then I just took two of the sagittals, because you can see the ACL sagittal, there's no patella, because it's not in the middle of the knee, it's off to the side, and on the one with the slice with the fibula on it, that's where the patella is. So it's miles out of place. I haven't shown you the TTTG because it's irrelevant. So what are we going to do? Do you think she's got patella? It's hard to tell.
It looks like it might be alter on the MRs, but not on the radiographs.
Yeah, that's right.
Does that matter because the MR's not done at 20 degrees in terms of measuring that?
Well, so for the patellotrochlear index, it's a full extension MRI, and unfortunately, what we do see is often they're at 20 degrees. So you have to slightly take that into account. Damien thinks there are ways that you can't measure it because it's not reproducible. I think that's quite fair. I would say she's borderline patellar here. Yeah. So severe dysplasia, borderline patellar, miserable 14-year-old, stop chance.
She'd assess her ligaments and also get long leg alignment views as well.
She's hypermobile. Do I need long leg alignment views?
You were concerned about femoral torsion, so
okay.
Just check there's no other obvious abnormality.
Clinically, I'm happy with it's moderate, moderate.
So I think in her case, if she's failed the normative management with a significant trochlear dysplasia, you have to consider doing trochleoplasty on her. And then once you've done that reassessing with your superior-lateral arthroscope to check where the patella was lying and see whether you need to do any interventions. I know you were saying before in your series you didn't often do acute MPFLs.
No. So I always do a medial repair, as I call it, restoration normal tension. So that guides the patella in. And actually, because this is an open procedure, I'm not scoping these. So I assess the patella overlap. So the trochleoplasty, like a patella replacement, lengthens the trochlea. So you get lengthening as well as deepening. So if you're borderline outer, pre-trochleoplasty, you're usually not outer again with trochleoplasty. So I assess that and then do the tubercle. If I'm not sure, I'll do the trochleoplasty first and then the tubercle afterwards. If it's definitely high, I'll do the tubercle first, because there's the osteotomy, not the repair, not the fixation, because it gives me an easier access to the trochleoplasty. So here we are. So I saw her last week. She's 3 months off the second side. So that's her second side X-ray at 3 months. That middle lateral X-ray, you can see we've resolved the crossing sign that was there beforehand, exactly as you pointed out. So we've got a nice new curved floor now. She's got a nice axial X-ray, spine X-ray, and she's already getting back into dance 3 months. And she smiles and I love scowl. Okay, so 16-year-old. So worsening anterior 2 years of sudden exacerbation, no particular injury, just got suddenly much worse, onto crutches, beginning to get a bit of depression coming in, missing lots of school, non-op again hasn't worked, lots of physio, lots of private physio, not getting anywhere. Again, borderline anteversion, quads hopeless, Patella-alta clinically, the TNS test was negative, so not tender really over proximal patella tendon, but tender over proximal lateral tendon. No apprehension. No patellofemoral irritability, so I could wiggle her patella around 20. Tibiofemoral joint was normal, and that's a scan there. Jim?
So a scan on the sagittal that demonstrates, I think, probably patella-alta.
Yeah.
There's no evidence of clearly of edema within that area, maybe at the inferior pole, something going on within the Hoffa's fat pad. And then in the axial view, you've got I think it's probably a decent roof, congruent patella.
So this is what David Dejour calls the empty trochlear sign. So we've got the trochlea, which is, unfortunately, I haven't got the sections on. So that's the trochlea at this level, where you'd expect to see the patella, and all we can see is the patella tendon.
Okay.
And then what's this here?
It's a tendinitic area.
Yeah, and this here.
Yeah.
So this is lateral patella tendon conflict.
Yeah.
Okay. So we've got symptoms and signs and radiology of lateral patella tendon conflict, and failed non-optimal management. So we're going to do
lower patella, so we're going to have to start it. Tubercle osteotomy and distalization.
This was actually my son's girlfriend who'd been neglected by the local orthopedic surgeons for years. And so this was the sort of some of the actually can't see quite so clearly as I can here, but there's just a little bit of hyperreactivity here, and this is the sort of stress riser that I'm worried about with these ones that I didn't use a plate with before. So I'm not very keen on impact activity until that's completely healed normally. I'm worried about fracture, from there going across. So that's why I'm spanning these with a plate now, and it seems to make a difference. She was one of the trials of sore screws. And then, so this is a 17-year-old girl. Painful instability, 2 years, multiple dislocations, although she hadn't dislocated in the last couple of years. She had instability, but not true dislocation, where she had had multiple dislocations in the past. Again, she's off school a lot, was doing music and dance GCSE, which she had to abandon. Again, mental health going downhill. She'd withdrawn from all of her friendship groups. She wasn't taking part in anything. Parents were really worried about her. She wouldn't look in the eye. So no hypermobility, normal torsion and angle. She had clinically patella-alta, positive apprehension test, wasted quads, no fusion. Patella subluxed off into extension. What am I describing? What are we going to find?
There's going to be evidence of patella-alta on the radiology.
Yep. So here are her X-rays. What can we see?
So does the lateral does look like patella-alta on the lateral, and I think there's probably a crossing sign as well. Probably.
Yeah, there is a bit of a crossing sign. Actually, on the AP, I find for alta, I know all those ratios are measured on the lateral. I find it really hard to assess, but on the lateral, it just the patella should basically be here, shouldn't it? And it's up here, so it's high and lateral. She's got a bit of a crossing sign. And this is her scan.
So it looks like she's got severe trochlear dysplasia.
Yeah, so she has really. So I ummed and ahed over this one, because it's not quite as bad as that last one, where there's a big dome. This is sort of a flattish tray with a bit, it is a dome, I'd agree. You know, and she's got patella alta. And just because she hadn't dislocated for several years, I thought that maybe I didn't need to do trochleoplasty there. She didn't have joint hypermobility. If she had joint hypermobility, I would have done trochleoplasty for her. But I didn't. So what did I do?
Distalizing double tubercle osteotomy.
And MPFL reconstruction. So the way I do an MPFL is with an endo button on the lateral side of patella, tunnel through patella, endo button, looped graft, and the two free ends into here, isometric tunnel. You can see that it looks happy. And that's the new tubercle fixation. So she came in smiling, no pain. She was absolutely delighted. She just got back from Glastonbury, and she's back involved with society and enjoying life.
Just wonder, how do you guide? How you
distalization? Yeah. So I aim for around about 30% engagement in trochlea and full extension. So from the MRI scan. She's got 0 engagement at the minute. So if you measure the length of the patella and take a third of it, that's roughly how much distance you're going to go. Inevitably, as with all these things, it's often about a centimetre. But I did one today which was 12. I did one yesterday that was 9, and another one yesterday that was 17. So it does vary. But that's how I work it out. And so that's what, and I think that if you now look at that on the AP, it looks like it's in the right place, whereas it didn't before. So hopefully that'll be okay. I'm a bit worried about dysplasia, so I hope she'll be all right. But, and she's less severe on the other side. On the other side, she's got less dysplasia and no alta, so I'm just going to do the MPFL. This was just a clinic note. So this is a 41-year-old lady with anterior knee pain. So years of anterior knee pain, last couple of months, worsening symptoms, knee collapsing, particularly downstairs. So downstairs is the hardest thing to do for your patellofemoral joint. So most patients will say descending stairs is the worst. And inclines, not locking or swelling. And then, so examining her, she's not mobile, torsion normal, good quads, no fusion, normal range of motion. She could extend the knee, but she's got a patella that's tracking off, slight apprehension, but seen as test markedly positive. So you've seen this already, haven't you? Pattern recognition. What have we got there?
So we've got lateral patellofemoral conflict with edema seen on the
plica, which you often see with these patients above the patella. So here, a big circle suprapatellar plica, and here. And this area here is where the patella, so she has got alta, so patella's hitting here, and the trochlea is here. And this is where her patella was bearing load initially. And then normal tibiofemoral joint, and then these are looking from above before I do anything. So she's subluxed out. This is a right knee looking from the top. Subluxed out, and then we've distalized without doing any medial soft tissue repair at all, sitting bang in the middle. So because she was doing that, I didn't need to do anything medially, and that's only now. So this is just a slightly off in a different sort of case. So this is a 67-year-old guy who plays a bit of golf. And is restricted to a buggy, 9 holes. He's can't enjoy that anymore with his mates. He likes to play tennis as well, but certainly can't do that. And he's at the stage now where he wants something doing about his knee. What do you want to know?
what he's tried already?
Everything non-operative. Paracetamol, cabbage leaves, change of shoes. He doesn't use a stick because he's embarrassed by doing that. Glucosamines.
What his expectations are?
To be able to return to golf.
So, I mean, looking at the radiographs, he's got osteoarthritis in the medial compartment and a little bit in the patellofemoral joint on the lateral. It's not too bad. I want to know, so if we're going down the route of operative consideration of whether a total or a uni knee replacement.
So you're going to do an arthroplasty.
Arthroplasty, I think.
Have you ruled out hydrocephalic osteotomy?
Well, he's always,
Where's the symptoms?
Medially. Good question.
He doesn't have a painkiller downstairs.
He does.
Could you scope and consider doing a PFJ and a uni?
What's the scope for?
Assess the lateral compartment and split it to side on the table.
Okay.
You could do it and then counsel him prior to his operation.
Right, so we're worried about patellofemoral joint? Okay, good. So who would do a uni? 1, 2, 3, 4. Yeah, so a few, half of us would do a uni. Total, bicompartmental.
He's got lateral osteoarthritis.
He has, yeah. Are they osteophytes?
So it could be a function of the fact that he's got arthritic process and it may not necessarily. So I think.
Is this a contraindication for unicompartmental?
No, it's not a contraindication, not at all. But at the same time, you may want to. So I think an MRI to assess his lateral compartment and see whether he's got significant.
Okay. So what would the Oxford group say?
So you could do
You base it on X-rays, not MRI scans. Clinical exam, so a lateral grind test. So I do a grind test in the clinic. So I press the medial compartment and bend the knee back and forth around 30 degrees of flexion. Lateral grind test you need to do around 70 degrees of flexion because that's where the wear is. And then examine the patellofemoral joint. Compress the joint, move the knee. Where does it hurt? It was